Why is it that in healthcare we so often blame ourselves if we're burning out, or we minimise our feelings, telling ourselves we just need to keep calm and carry on? More often than not, it's the system that causes burnout, and blaming ourselves is just going to drive us further into feeling anxious or depressed. This week, I'm joined by Dr. Richard Duggins, who's just written a book specifically to help healthcare professionals avoid burnout. This episode is jam-packed with insights to help you figure out whether you're in danger of burnout or if you're simply working through it to the detriment of other vital parts of your life, like your relationships or, frankly, your own happiness. Burnout doesn't always look like a dramatic event. Stress and moral injury can build up over time. So if you find yourself irritable or you've noticed a change in empathy for your patients, this episode has got some really practical steps for you to follow. There's loads more information in the show notes, which you can find on our website.
I'm Dr. Richard Duggins. I'm an NHS psychiatrist and consultant psychotherapist. And I work for and lead our regional North East and North Cumbria staff mental health and wellbeing hub. And I also work as a psychiatrist in the outstanding NHS Practitioner Health. I'm also the author of a new book, Burnout Free Working, and I'm really pleased to be here today.
The book is really great, and I would encourage any listener to check it out. And it's absolutely packed with such useful information. And the thing I really liked about your book is it is talking about the workplace and also stuff you can do as well, because the biggest issue with burnout and with resilience training, with wellbeing and stuff, is people feel like they're being blamed. Resilience, victim blaming, and that's something you talk about in your book. How do you see resilience, victim blaming showing up?
It's one of the motivations for writing the book, because the people coming to see me often feel it's a personal weakness, that it's some strength, they're letting their team down. And actually, that's not what we see. And when we speak to people and they tell their histories and they can start to see it, what we really see is what's going on is something in the system. It's a change or some change in the balance of what's going on around people rather than what's going on inside people. So I often talk about radiators and drains. So what are the things that are radiating energy and keeping people resilient, but also what are the things that are draining their energy and making them more likely to burn out. And what we see clinically is a tip in these radiators and drains.
And I did laugh in the book because you talked about the fact when you talk about this and you show people the stress curve, which we use all the time, which simply plots your performance against pressure. And as the pressure increases, initially you get this good stress, don't you, where you perform well. But then as the pressure increases, you tip off the top of the curve and your performance starts to decrease. And you said you often hear sort of audible gasps when you talk about this, as people realise. That happened to me in a training session. A woman, it was a non-medical training session actually, but a woman ran out of the room really in distress, and I caught up with her at the break time and said, I'm so sorry, okay, is that something I said? She said she'd recently been off sick with burnout, and it was such a relief for her to know it wasn't her fault and there wasn't anything wrong with her. So why is it that we do blame ourselves? And do you think people in healthcare blame themselves more readily than other people?
I think it's a narrative throughout many professions in high stress. I think it's certainly there within healthcare, but I think it's there within teaching. I think it's there within social work. It's there within law. I've done some work with the police. It's certainly there within the police. So I think it's a misunderstanding. I don't think resilience and burnout are understood very well. So I think it's a misunderstanding. And, that's why your podcast and things like that are so important, because they correct these misunderstandings. But I also think organisations at times have found it more convenient when people are struggling with burnout and their mental health to say, actually, it's that individual, and to scapegoat them rather than to ask the harder questions, which is, what are we doing that's burning out our staff? What could we change? It is easier to blame the individual, I think.
Yeah, and as medics, I mean, we have been used to pretty high pressure for most of our careers, haven't we? Starting with doing A-levels, quite frankly, and then med school with all those exams and working much harder than it seemed like than anybody else who only had, my husband only had like 3 lectures a week at uni. We were there 9 to 5 every single day. And then you go straight into house jobs, which were incredibly pressurized. So do you think we have our normal pressure gauge is just set a bit higher than everybody else's, perhaps?
Well, it's certainly the case that the medics I meet in my clinic are incredibly resilient people. They can manage a lot of stress, but we are all human and we can all only take so much. And at times there will be too much stress at work, often combined with too much stress at home, combined with too little support or a change in support. And we all reach our limits. And at that stage, we'll start to develop problem stress or burnout, and may even progress to anxiety, depression, or some physical complications. So it's, I agree, we are used to and trained to manage high stress, but too much for too long will burn us all out.
And do you think in the people that you've seen, it's a problem with the drains have increased? Or is it a problem that the radiators have decreased? And actually, it might be quite helpful for you to just tell us what you think the drains and radiators are, particularly in healthcare.
Yeah, absolutely. So the drains there's 3 drains, typically. They are work stress, both the hours worked and the intensities of those hours worked. They're home pressures. So that's also, what's going on at home. Are there changes? Are there disputes? Have we suffered a bereavement? All sorts of pressures that are at home, caring responsibilities. And then the other drain, which is a really interesting one, is negative experiences about work. So this is about how we feel about work. And this is very much the culture of work. This is our support at work, how we're treated at work, how investigations are handled at work, how we feel valued at work.
When you talk about negative experiences of work, are you talking about what the HR department would call employee engagement?
It's related, but in my mind is slightly different. So certainly negative experiences at work do stop employee engagement. But no, I'm talking more about the way we feel our work treats us. So how we feel treated by our organisation, our line management, our colleagues, how fair work is. So it's more of a cultural thing about work. If we're exposed to moral injury, those sort of things that affect our relationship with work.
So it's not just about the hours and the workload. It's not just about the pressures at home. It's actually about how we're treated by people if we feel the culture is supporting us and is fair. So you can have a high load of hours and high workload, high load of home pressures, and be just about coping. But then suddenly you start to get these negative experiences at work, and that can then tip you over into burnout.
Yeah, that's what we see.
That's interesting. So do you get patients coming in going, well, the workload hasn't changed, so I don't quite understand what's going on here. We've sort of got the same workload, but for some reason things are much, much harder.
Absolutely. Yeah, absolutely. And people tend to just look at the workload. They don't tend to look at the other drains. So the radiators are how much support we've got. And we're doubly blessed if we've got support at work and at home. So this again is the culture of work, line management, but also our colleagues. Have we got a buddy at work? But also have we got support at home? The second one is whether we've got any opportunity for fun and social time. So that's often done outside work, but to be honest, why can't work be fun? It should be fun at times, but these are our hobbies and activities. And then the third one, which I think is really helpful for medics to think about particularly, is there some intellectual stimulation in our working week? So this is, do we feel stretched and developed within our working week? And some people can have extremely busy jobs, but there's something in that week where they really look forward to, they really enjoy a particular clinic, a particular role, an education role or something like that. And that really helps us keep going. So that can be a radiator.
I love that. I remember in one of my GP jobs, I was incredibly stressed, but incredibly bored at the same time. And I was like, how could those two coexist? But you've hit the nail on the head. Yeah, there was a lot of, the workload was really, really high, but there was really at that point no intellectual stimulation. And actually I fixed that, not by changing jobs or changing the workload, but I think started to doing a master's or doing some more training. So that was something that suddenly started to intellectually stimulate a bit more. So we don't often think about that, do we?
No, absolutely. And it's important to think about. It's also one of the things when people get busy at work and they start to burn out, the thing they often drop is that what they see as that optional extra, which might be the most intellectually stimulating bit of their week. So they might stop the teaching or the additional clinic they offer or the minor surgery or something like that. And actually that's a real mistake, because you're dropping the thing that's keeping you going. But you see it quite often because people retreat back to doing the core, often the bit that isn't that stimulating and enjoyable.
And you talk about that in the book, don't you, with the funnel of exhaustion by, I think, Marie Asberg, where, yes, you just give up doing everything that you need to survive mentally and physically. And yes, I certainly talk about that a lot, but more in relation to the well-being factors, but actually learning and growing, that is a well-being factor. So often I think about, well, we just give up exercising, don't we? And we give up the yoga class and resting. But you're right, often, because the learning and the developing feels like an optional extra, that is just put on the back burner. And I have lost count of the amount of doctors who've said to me, well, I just haven't got time to do that master's or do that course that I really want to do. When actually what you're saying is that could actually be the thing that saves them from burnout, weirdly. But how do you do that, though, without it just becoming one extra thing to do, one extra pressure on workload and time? Because that is the real crux of it, isn't it?
Yeah. Well, avoiding burnout and then managing burnout, well, I don't need to tell you, it's really hard. I mean, I run a therapy group for professionals who've burnt out, and these are great professionals, very creative, and they'd have solved their problem on their own if they could have done. But these problems are really difficult to solve, and that's why the group's so helpful, because people get to think together. And sometimes it requires really difficult decisions and courageous conversations, and to try and get that balance back, the balance between the radiators and the drains back. And I think one thing I certainly see with the patients and the professionals I'm working with is that often requires not them having to solve it all on their own, because they would have done all that already if they could have done, but having to reach out and have those conversations about, how do I get this balance back? Who can support me with this? Who can help that balance in my work, so I'm not just burning myself out doing lots and lots of hours of unstimulating work when I know I can contribute in other ways too.
But then we've got another problem, haven't we? And I know all throughout the whole of your book, I've noticed the theme is reach out, get support, connect, which I totally agree with. But the problem I see is that in healthcare, often the people that you reach out to are your colleagues who are in the same boat. And often they have a vested interest in you keeping on churning through the workload that might not be stimulating to you, to keeping you going so you can do the service delivery. You can reach out to your manager, who is probably even more stressed and burnt out than you. So that's another problem for them to deal with. So I'm not sure you're going to get the best support and unbiased support from people at work. So then the question is, well, yeah, you can reach out to your friends and family, but they don't really understand the workplace and what you're going through, particularly if they're not in a healthcare context. So who on earth do you reach out to for this support?
Yeah, and there aren't simple, easy answers, and I think it requires quite a lot of courage, assertiveness, persistence. I think a key thing that people start to accept when they come forward for support and help is, actually, this is really serious, what's going on. Burnout is horrible. It's a terrible feeling. And it can lead, if you don't manage it, to anxiety, depression, physical health problems like high blood pressure. So it needs managing. And as good work is good for us, bad work is bad for us. And I think it requires us, in a way, to take a stance where we're saying, actually, I can't sustain this. I need changes to happen. And that can feel very difficult. But actually, you burning yourself out, having to take time off work, or performing poorly because you're burnt out and making errors or mistakes or having poor conversations with patients or colleagues, isn't worth it. It's not helping anyone. And it's not helping your colleagues, although it may feel like it. So although organisations and colleagues might want to turn a blind eye at times, they might want to just keep us going until we burn out. We really aren't doing us any favours in that, but we're also not doing them any favours for that. We're not doing our patients any favours.
I totally agree. And it's this sort of weird cycle of people saying, well, I haven't got time to do anything about this because there's so many patients I've got to see, or I can't say no because it will let people down and it'll pass the stress on, or I'll get a complaint and then I'll say, okay, fine. Well, you may get a complaint if you say no, but what's going to be worse? The complaint when you've said a well thought through no, or your colleagues may be thinking you're letting them down. We don't have any control over that, or properly letting them down when you're off for 6 months. I mean, I'm not saying, that's not a judgment, but you won't be there to do the work, or getting an even worse complaint because your judgment's gone. And we know that doctors that are near a burnout make many more mistakes than people who aren't. So then you're going to get that complaint and let people down anyway. It would have been better to have that difficult conversation in the first place. So that's one whole thing about, setting boundaries, saying no, having those conversations. And as you were talking, I was thinking about the difficulty of finding people to reach out to. But I've had a situation, not about stress, but there's been a situation where I want to find out about something and I'm really not sure about who to contact. I'm thinking, oh gosh. And my other half said, Rachel, lots of people you could contact. And I thought, okay. And I just sat down and I wrote a list. So it turns out, having said, I don't know what to do, I don't know who to ask advice from, there are at least 10 people I could literally email and ask some advice from, but it takes a bit of thinking, a bit of putting my neck out there, and a bit of being ready for people to say, actually, no, I can't help you type thing. So it probably isn't that we don't know anyone who can support us, right?
Well, absolutely. And for me, it's one of the joys of being a doctor and being in the NHS. And for me, one of the key values and why I do this work really for being a doctor and in the NHS is we help our colleagues. We are there for our colleagues. And I increasingly believe that actually helping our colleagues stay well is, for all of us, whatever our roles, is the best way we help patients, because healthy, thriving colleagues deliver great services. So I almost think it should be our priority. The other thing I was reminded of when you were talking was how we change culture. And I think we have an opportunity sometimes, especially if we're reasonably senior, to do that. And I was thinking about, there was a service I worked in about 10 years ago, and we used to see all sorts of doctors. It was a self-referral service. Lots of doctors came to us, really popular, but no surgeons came to us. So and I was like, well, these surgeons are under a lot of pressure. I know that. I've got friends who are surgeons, but they never came to us. And then one day, a very senior surgeon came to us. He was burnt out. He'd become depressed. He referred into our service. He did very well, because most people do. And then he went back, and this was the remarkable thing he did. He talked to all the other surgeons in the region and says, look, this happened to me. I was overworking. There was a lot going on at home. I went through to this service. I'm much better. You can see I'm much better. And then the floodgates opened. And we never, ever had any problems with surgeons coming through to our service. So that person, I'm sure he doesn't know it, but probably saved a lot of people's careers, will have benefited patients, and maybe saved some people's lives. So I do think there's something else about just battling on and waiting for burnout to hit us, and doing it silently doesn't help our colleagues either.
No, it really doesn't. And the minute you share something, the shame dissipates, doesn't it? And let's face it, we still all feel shame when we think we're not coping, because we feel, I'm not good enough. As a doctor, I should be able to cope with everything, which is totally bonkers thinking. It's this superhero thinking that it is so unhelpful for us. But the minute someone senior tells their story, it's like, okay, yeah, we can do it. And we've been involved in coaching programs for new to GP fellowships, and there's coaching programs around the country that are fully funded for doctors and not being used by anybody, which is total madness. Now, either people just don't know about them, that could be one thing, but I think people firstly feel they haven't got time, which is again total madness. We'll talk about that in a minute. Or people maybe don't want to admit how bad things have got. Why do you think people aren't using these services that are available to them? They're out there.
I mean, there's a lot of talk about how far we've come on about mental health and destigmatizing it. And yet a lot of professionals I still meet with, a lot of doctors I still meet with, they're really ashamed to be meeting with me. The line usually is, I'm sorry to be wasting your time. I'm sure you see people a lot worse than me, and a sense of a weakness, a failure, letting their colleagues down. And it's still there. And and it's as I said earlier, it's a misunderstanding of what burnout is. It's not true what they're saying. And when they tell their stories, they can see it's not true, but that's there. The other thing is, I think people need to trust these services. They need to trust that the services will be for them, that they'll be rapid to access, that they'll be confidential, and the outcomes are really good. I mean, NHS Practitioner Health is a fantastic example of that in the UK. So when Claire Gerarda set it up, she said, if we build this, people will come. And I'm not sure people were sure about that at the beginning, but it was built. People come to NHS Practitioner Health. They get really, really well. They start thriving. They then go back and tell their teams about their positive experiences. And the service has grown into the kind of, massive trusted services it is at the moment. So I think it does take a little bit of time to make people trust things. I think people can worry that if they come through to help, that it will be opening a kind of Pandora's box and that they'll suddenly be off work and they won't be able to get back to work. And that's not true at all. You come through to help, you'll do really, really well. It's when you don't come through to help that the problems can come.
I think as well, when some of these services were first set up, I'm thinking of a particular coaching service. It was like, oh yeah, come and see us. And they'd give like 1 day of training to people. And then so people would use it and think, well, actually, that wasn't very helpful because actually they saw someone that wasn't very experienced and also almost felt like they were just trying to persuade them to stay working rather than, or they were doing mentoring, which is great, but probably what wasn't needed at the time. And so they're put off. But I think things have very much developed and improved since then. I think one of the reasons why people do put off getting help is they don't recognize it. And you talk about this in your book, that the burnout cliff that people go along, think, well, I can't be burnt out. But I've spoken to someone who's a medical director of wellbeing in a local hospital trust. They surveyed their doctors recently using, I think it's the Maslach inventory. 50% of their doctors are working in burnout. And we are led to believe that actually burnout is so severe, you'd know when you're in it, you can't carry on when you're in it. But actually, a lot of people are actually working in it. So absolutely. And I've had those thoughts, just the same as your patients. Well, I think I might be wasting your time because I don't think I'm actually that bad. But you actually are. But almost you've felt like that for such a long time, or even, dare I say it, for most of your career, it's become normal to you. So is it true that we've almost normalized burnout and a lot of it are working in burnout without even knowing it?
Yes, I think that's right. And I think I talk about a culture in high stress professions, particularly in the NHS, where we keep calm and carry on. We listen to Dory in Finding Nemo. We just keep swimming. That's what we do. And that is terrible burnout advice. It's a way to get through a difficult night shift. But, it's like trying to run a marathon in the way that you handle a sprint. So keeping calm and carrying on doesn't work, but it's the way that it's our go-to, I think, in high stress professions. So we keep our heads down despite, feeling a lot of problem stress, early signs of burnout, even quite severe burnout. And we just try and keep going. What we do is we try and protect our work and the core work, and often other things are, we're neglecting home life, we're neglecting our social activities, we're becoming quite isolated from our community. But we do try and keep calm and carry on. And some of that, I think, is because doctors, and I see this all the time, are really quite hopeful, optimistic people. And they say to me, it will get better. It's just a really busy spell.
Yeah. Next year, when I get my new colleague, it'll be fine.
Yeah, absolutely. So you hear a lot of that, and and hopefulness is wonderful. We need that when we work with our patients, but it can get to the point where it's fooling yourself. And the danger with that stage is what I call the plateau, where people are just putting their heads down, hoping it will get better. But the danger with the plateau is you end up sleepwalking towards the burnout cliff. So it comes to a point where things go, there's too much for too long, and then there's one thing, the straw that breaks the camel's back, and that will potentially take you off work, or you'll have to then reduce your commitments, and that's where we really don't want to get to. So it's much better for people to act early to try and recognise things. I also think you're right that people don't necessarily look out for them. So one of the things I do when I'm lucky enough to be able to do some workshops with people is spend a bit of time saying, what are your signs of problem stress? Do you know them? Do you know them as a tick list? And often people don't know them, but really they should be on our dashboard. We should be monitoring them. And, we should be watching out when we're not sleeping as well, when we're withdrawing, when we're becoming irritable, when we're getting muscle tension. But I'm not sure people are monitoring those. Or if they do recognise them, sometimes they're ignoring them.
And I've just had this real realization as I've been talking to you, because this burnout cliff is really interesting. And you have it in the book as, you're this wiggly line, you go along and then suddenly you go into burnout. Because the question I've had for a long time is, okay, why are so many doctors able to work in burnout when the traditional advice is their performance will go down? So you can't perform if you're in burnout, yet they are still just about performing.
That's right. And I think it's, there's two people I think of in the kind of history of burnout that I often go back to. And the first one is, he's got a wonderful name. It's Dr. Herbert Freudenberger. And he was a psychoanalyst in New York in the 1960s. And he burnt out. And then he coined the phrase to describe his burnout. And he was doing a public addictions clinic during the day and doing a private clinic at night. And too much for too long with too little support. And he coined the word burnout because it reminded him of what he was seeing in New York at that time, which was the burnt out buildings. And he said, if you look at a burnt out building, it looks okay from the outside, but inside there's a kind of desolation and emptiness. And he said, that's what I feel like. People look at me, they think I'm fine, but inside I feel terrible. And that is, I think, the burnt out clinician at work. They're protecting their work. They look okay, but inside something really quite serious is going on. But when the straw that breaks the camel's back and they need to take time off work, it sometimes takes them by surprise, but almost always takes their colleagues by surprise. They don't see it coming. The other key name is the name you've already mentioned, Professor Christina Maslach, who did the Maslach inventory. And she described burnout as three things. So I think at that stage she didn't talk about performance, but what she talked about is emotional exhaustion. So that kind of absolutely exhausted at the end of the day, all you can do is sit on the sofa and have a glass of wine and fall asleep. Emotional detachment. So that kind of robotic kind of compassion fatigue feel, not there for your colleagues and your patients. And then the third thing she said was a loss of joy in work. So that kind of where you don't feel that joy that brought us into medicine or these high stress professions. You don't feel those small wins anymore. And lots of people have those three symptoms and are still at work and manage it. And it's only, I think, much later in the burnout kind of well-worn path that you get the drop in work performance. But because people stay off so long, you get a sudden drop. You get this kind of slow burnout and then a very quick burnout.
And this diagram is in your book, that you've got this plateau, which is slowly going down, which is your performance, and then suddenly the burnout cliff where it suddenly drops down. But what really struck me about what you said, Richard, is that actually your performance isn't carrying on well. Your performance at work is, so you protect your work. But if you look at your performance at home, so I've drawn another wiggly line underneath, and that is your relationships. That's your thriving in life. That's your family life. That's any friendships, your exercise, your well-being, all that, your performance in terms of thriving in life. Well, that is starting to go down, and you'll drop all of those as long as you are protecting your work. Well, thinking, well, I can't be burnt out because I'm still performing fine, even though, like you said, joy has completely gone. You're this hollow, empty shell with nothing in your life but work because you've given up doing anything that brings you happiness, joy, or whatever, so that you can protect your performance at work. And then something happens, the straw that breaks the camel's back, be it a complaint or a tricky patient or a colleague going off sick or maybe something happening at home, and then suddenly, boom, your performance everywhere plummets. Is that a good interpretation of what you've said?
Yeah, I mean, it's exactly right. And that's what we see. We see people protecting work at far too heavy a cost to them personally, and to their families and ultimately to work. So you might see somebody, in fact, I'm thinking about somebody who, example of somebody who's just had a baby, but they've also just had a promotion. So that's great. These are great things, but massive increase in home and work stress. Because they've had a promotion, they've also changed line manager, and the new line manager isn't very supportive. They're expecting them to get on with it. So there's been a decrease in support. But the way they managed that is focusing on work. So working really hard, focusing at home, but absolutely no time anymore for themselves. So they've stopped running, they've stopped seeing their friends. They become more isolated. They don't come out of their office much, so they're not talking to their colleagues unless it's in a Teams meeting. And they're not doing anything fun at work or enjoyable or stimulating. And that's where it tips. So you get a change, and then the way people manage that change gets things even more out of balance.
That makes a lot of sense. And the problem is that just the time where you are being promoted, where you are taking on leadership experience, often coincides with life stuff going on, babies, kids, teenagers, elderly parents, all that sort of stuff. So you can see there's a lot of things that are going to break the camel's back, as it were. And you also talk about curveballs in the book. Are these things that will also like plummet you down that cliff quicker?
Yeah, absolutely. And I talk about these because a lot of people who come and see me in these conversations, the conversation initially is all about work, and work is really important. And they probably wouldn't be seeing me unless things were very demanding at work. But there's also often things at home, and it's only home only comes in when I often ask about it. Well, what's happening at home, and I talk about curveballs because there's typically kind of 4 home curveballs that are important, but also we can have strategies to manage. And these curveballs come from interpersonal therapy, a type of therapy that I'm trained in. But the big curveballs to watch out for are change. So has something changed at home? So the example I gave there, new baby, big change at home.
Moving house would be one. Even though it's a positive change, it's emotionally very draining, right?
Yeah, absolutely. So lots and lots of changes happen in people's lives. Caring responsibilities, as you've said. The menopause is a massive, massive physical change. So the other thing that's going on is maybe disagreements at work, but disagreements at home. So, if you're working very hard, very long hours, things can often be a bit difficult at home. How do you manage those disagreements at home with a partner, or sometimes with parents, or sometimes with children? They're very stressful.
Yeah, just say that. I had some friends who there was a massive dispute going on with their neighbours. And that I couldn't quite work out why it was affecting them so much. I mean, it's not a very nice thing to happen, but it absolutely knocked them sideways. For 6 months, they couldn't think or talk about anything else. So it's a big thing, isn't it? Whether it's with parents, families, partners, or neighbours, or anything else, really.
And absolutely. And you throw that in alongside a very busy job, or a job where you're not particularly supportive from, that will be the thing that will tip it. So we've got change, disputes. The third one is bereavement. And natural process, losing people, natural process, grief. But do we ever allow any time for it in healthcare? Sometimes you might get 5 days off or something like that. And people are expected to work just the same alongside being bereaved. And that is a very big ask and often not very possible. And then the fourth curveball I put in is loneliness. And this is something we don't talk about a great deal within high stress professions, but we do see people can become quite isolated because of how many hours they're working and how intense they're working. But a group that I particularly think about here are international healthcare graduates who are coming over to the UK. It's a wonderful opportunity to come over here and develop their career, but they're quite isolated and expecting to do really difficult work without the normal support. So isolation can be really important. We can really feel it when we've got a good friend we rely on, a good buddy moves away. That can be the difference. So isolation's a really important curveball to think about as well.
If you can tell someone's heading toward that burnout cliff, how do we get people to take action? Because I'm presuming most people leave it till it's too late.
They do.
Or leave it too late, not till it's too late. Nothing's ever too late.
No, and absolutely. And people come forward to services for support when they're very burnt out, they're anxious, they're depressed, and they still do really well. It's an important message here. But yes, we can avoid an awful lot of distress for ourselves, our families, our colleagues, our organisation if we come forward earlier. The group that are really good at coming forward earlier are the people who've burnt out previously. And I love seeing people who've burnt out earlier in my clinic because they say I'm coming forward because I'm starting to feel these symptoms of problem stress. They've been with me for a few weeks now. I'm a bit worried because I'm not kind of caring quite as much for my patients. I used to feel a bit robotic. I'm not going down the route of burnout again. I'm coming forward for some support. And that's exactly the great thing to do. So what would be wonderful, and one of the motivations for writing the book, was, can people do that? Can people learn from all of the people who come forward later to come forward earlier? Because if you come forward earlier, it's much easier to get things back in balance, to balance out your radiators and drains, to make changes that protect you from burnout. It's much easier, it's much more effective, it's much quicker, and it's much less disruptive to everyone. But it's something about self-monitoring, it's about recognizing those symptoms, but equally important, it's about taking those symptoms seriously. Don't just ignore them and keep calm and carry on. Don't just keep swimming. Stop, reflect, but also act. Do something about it.
I think people put off coming, A, because they're not recognizing it, and because everyone is in the same boat as them, everyone's working in burnout. B, they think they're only deserving of treatment when they are in full burnout. So actually, no one wants to see me now. And to be honest, there have been anecdotal reports from people that have written in to the podcast saying, well, I was feeling really stressed and overwhelmed. I went to see occupational health. They said, the only thing we can do is sign you off. That was it. Or they say the GP goes, and to be honest, with most GPs, the only thing they can do is say, well, do you want to take time off? They can point people towards, well, there's practitioner health and there's some other services, but they themselves, that is they don't have time in 10 minutes to go through, okay, let's look at your radiators and drains and coping mechanisms and all that sort of stuff. So people are very fearful that they're just going to be told to take time off, and then they'll be going against medical advice. And I think it's a real conundrum, because we've seen, if you look at the stress curve, I think if you're going to get some help when you're at stress and just before overwhelm, and someone tells you to take time off, then actually sometimes it's absolutely what they need to do. But sometimes it's like the last thing you want to do, and it'll make things a lot worse for you. Yes, you need to rest and make some changes, but this prolonged time off that most people are just told to do as a sort of panacea for burnout management, that's just like, that's not going to work for me right now. And so let's wait until I 100% can't actually go into work just to be told to take time off. Now, I know I'm being a little bit harsh, but I think that's genuinely some of the experiences of our listeners.
Yeah, and I've heard people report that to me as well, and who've gone to other services, and and other services are limited. They haven't got the knowledge. I mean, we're still quite early with our understanding of burnout, I think, and it's not greatly understood. It's still not considered a medical condition. I don't really understand that, but it isn't. So I think you're right. But what I would say is that if you can come forward early, it is much easier. It's what you should be doing. To take examples of us as doctors, we don't really say to our patients, let's not sort this out early on while it's mild. Let's just come back when it's really, really bad, and then we'll tackle it. Because it's much easier to sort things out when they are mild. It's much, and you'll need much less input, and there's a greater range of people who can help you when it's mild. And it may not be that you'll want to come through to service. You might want to do some coaching, or you may have some peer support or things like that. There can be other things. So it is, I would say it's really important, people.
I mean, this is why we have our Shapes Toolkit system, because we think there is nothing between stress and burnout for people often, even to help themselves, because with the best in the world, getting an appointment to talk to people, that might be a few days away or even a few weeks away. But there are things that we know help, like staying in your zone of control, your zone of power, working out what you're in control of, what you're not, actually facing reality, having conversations, learning to put some boundaries around your time and workload, things like that, which are really, really helpful and can just pull you back up that curve and away from the burnout cliff.
Yeah. And if you act early, I don't know whether this metaphor works, but sometimes I think of it a bit like driving a car, that if you steer a little bit and use your brake a little bit, that's how you drive. What you don't drive is wait until you hit the corner and then just go like that and slam your brake on. So actually, if you do take things seriously and you do monitor things and you do come forward and make the sort of changes that you're suggesting, they often don't need to be massive changes. What you want to be doing is self-correcting and making these small changes and learning these ways of doing it early on.
So what do you wish your patients had done or been able to do or had support to do to self-correct early?
Well, what I see people doing when they recover, I mean, it's individual, but I think there's five key things that I see people do. The first one is that if their basic needs are out of whack, they do something to attend to it. So that is, if they are working massive hours, intense hours, they're not getting any time to talk to their colleagues, not taking their annual leave, or if it's something at home that is out of whack, they try and address it. Because the danger is, if you take time off and you come forward for help, you will get better. But if you go back to the same problems, it only lasts so long. And there's good research evidence that shows that too. So I think if it is about basic needs that are making you become unwell, then you need to address it. The second one is decompression activities. So this is the idea that stress builds up on us every day. So we need to do something regularly to manage that stress. And that could be something that's active, like running, joining a choir, or it could be something that's quieter, a restorative niche, like, might be reading, might be mindfulness. I've heard you speak to Paula Redmond. She talks about knitting. These are all really important things, and they're different for different people. So, don't listen to somebody who says, oh, you should go running if that's not what you want to do.
My idea of hell.
but do something that you like to do. Now, Matt Morgan is an ICU consultant. I love the way Matt Morgan talks about this. So he talks about early on in his consultant career, he was sort of soaking up this stress, and he found himself perhaps drinking a little bit too much, or more than he wanted to, and also being a bit irritable. And he talks about the idea of what he discovered, which a kind of brainwave came to him when he was kind of bathing his young children, and he talked about squeezing the sponge. And he said the idea that came to him was that at work, he was like a sponge for stress, and he was filling up with stress. And because he was over full, that he wasn't coping very well. He was, taking it out on other people sometimes. But he said what he learned was that to be a consultant and sustain his career, he needed to regularly squeeze the sponge. He needed to do something to get the stress out of him. And he talks about the various kind of activities that he made routine within his week to manage his career. So that's a really good one. The other thing is social support. So having your support team, knowing who's there for you at work and home, and really, really reaching out for people. And it's not just about a shoulder to cry on. Just those normal kind of everyday social activities alongside people, those chats, before and after meetings, those chats in the coffee room, or those, just those chats down the pub or in a coffee room are really, really important for our health. The fourth thing is a don't do, which is to avoid false cures, to avoid things that are unhelpful, like drinking too much. I'm seeing some professionals are using gambling, and this is a way of kind of taking you out of things, but it doesn't solve the underlying problems, and can become in time a bigger problem than the underlying problem. And then the fifth thing is what I see people do, and I've mentioned this already, is they keep calm, but they nip things in the bud. So people get really good at taking their well-being and their mental health seriously, and they look out for symptoms and signs in themselves of when things are getting out of balance, and they act quickly to do something about it. So they don't keep calm and carry on. They keep calm, nip it in the bud, do something about it. And that is a really rewarding change to see people make.
I think we're quite bad at doing that. I'm thinking of friends that I've had in the past who have been quite flaky. Like, they haven't been doctors. Doctors always, doctors turn up when they say we will. We'll go out when we do, but some non-doctor friends have been like, I can't come out this evening. I'm just feeling a bit tired. And I'm like, gosh, I would never cancel anything just because I'm feeling tired, because we've been programmed that tired is just normal. So you wouldn't, but actually looking back, they were nipping it in the bud. They're like, actually, I can't do that tonight because I know I don't have the emotional capacity for it. I've just cancelled that. I'm not going to do that. And yeah, they recognize it and they do it. But I think in medicine, we're like, oh, well, that I can keep going because I always had. And when I was younger, I did 120 hours a week. Therefore, I can manage that now. And yet this weird mindset we have, isn't it?
It's interesting, isn't it? Because the other thing that we are quite good at medics, especially for our patients, is taking control and advocating and acting. But when it comes to our own well-being, we're not very good at it. But we have got those medical skills to, we're not normally afraid of acting. We make difficult decisions, but we need to start doing that for ourselves. So I think a lot of high professionals in high profile jobs have got these skills. They just haven't yet harbored them for their own well-being.
The other thing, it's just come to me, it's a bit of a play on the word acting. We like to get into action. We're very good at getting into action and solving problems, but actually sometimes the action that we need is to subtract. So I'm just thinking, it's actually very hard for me to go, I actually need to sit in my hanging pod in the garden for an hour and read a magazine. That's what I need. I'd be much more, but I need to do this, and the other. So if we can change resting and subtraction into an action that we know is good for us, maybe we'd be more keen to do that. I mean, it's interesting. You've talked about those 5 things, and actually nowhere there have you talked about therapy and counselling and psychotherapy and stuff. So where does that all come in any of this?
Yeah, no, it's a really good point. So people who are coming through are making these changes. And I don't think you have to be in therapy or in a therapeutic relationship to make these changes, but people are doing that within a therapeutic relationship. And I think there is something about coming through to a support service or a wellbeing service that allows you to stop and reflect and think, actually, things are out of balance. What do I need to do to kind of correct this? So that sort of therapeutic support can be really helpful in helping people reflect, take things seriously, but start to make a plan and making those steps and goals and focus. And I don't think that, if you're coming through early enough or with burnout, it doesn't have to be a long time. You can do that within, a relatively brief therapy, 6 to 12 sessions, maybe even less actually. So that's important. Where therapy does come in, I think, is if your burnout's gone on for a long time. So some people will be on the plateau, will be prioritizing their work, become really quite severely burnt out. And if you're still at work and you're still under a lot of stress, it's reasonably easy for that burnout to turn into a medical condition like anxiety or depression. So it's I'd see it as rather a continuum of kind of problem stress to different levels of burnout. And then if it's still not managed, you run quite a high risk of developing anxiety or depression or physical health complications like high blood pressure. And I think if you're moving into that anxiety depression area, then that's where therapy comes in and an evidence-based therapy comes in. It may also be, and professionals tend to be a bit resistant to this, it may also be a conversation about, actually, if I've got anxiety and depression, do I need to consider some medication here to treat this? But most anxiety and depression, the first step would be therapy, and it would be an evidence-based therapy like CBT or IPT would be the top ones and the evidence-based to do.
Most of us sort of know what CBT is. What can you just explain what IPT is?
Yeah, so IPT is type of therapy developed for depression. It is available in the UK. It's available in most primary care services for anxiety and depression. It's also developed in some secondary care. We have got IPT specialists within NHS Practitioner Health. And within the service I work in regionally. It's an interesting therapy because it was developed by somebody asking therapists, if you're treating somebody for depression, what do we need to have in this therapy? What does it need to look like? And they all wrote a big list, and the therapy of IPT was designed upon that. And CBT tends to be about modifying your thoughts, distorted thoughts, and then that leading to a change in your feelings and behaviour. IPT is much more about looking at your social support and your relationships and who's there for you. And also we talk about in IPT the idea of antidepressant activities. So often when people become depressed, they stop doing the things that are good for them. So they become very tired. They think they're no good. They're not good company anymore. So they stop seeing friends. They stop doing those nice things because they're too exhausted to do it. So we focus on people getting those things back into their life as well.
Okay, that makes a lot of sense. And can I quickly ask you about the relationship between anxiety, depression, and burnout? Do you think that all burnout, if it gets severe enough, turns into anxiety and depression?
No, I don't think all burnout does. I think all problem stress does. So if we start off with problem stress, if we're in problem stress for too long, we'll become burnt out. And then if we stay in burnout too long, we'll become increasingly burnt out. Burnout is a spectrum, but some people will then, if they're severely burnt out, will have a high risk of developing anxiety and depression. But not everyone will, but quite a lot will. And the longer you are burnt out, the higher your risk of developing anxiety and depression is.
And is the other way around true, that if you suffer with anxiety and depression anyway, are you at high risk of burning out?
I wouldn't say necessarily so, because what determines whether you're at risk of burnout is what's going on around you. So we burn out because of those balances between our radiators and drains, when the drains are high and the support is low. And that is the same for everyone. So, whether you've got a history of anxiety or depression or whether you haven't, whether you're going to become burnt out or not is because of what's going on around you.
And what for you would be the red flags that someone in burnout is tipping also over into anxiety and depression?
So it's the diagnostic factors for anxiety and depression. So for anxiety, it would be, feeling worry and anxiety over most days for several weeks, probably over, to a couple of months, really. That's kind of there, often goes alongside physical symptoms such as heart racings, sweaty palms, those kind of things. So that kind of feeling, that protracted, constant feeling, and alongside those physical feelings as well. Depression is a feeling of being low or a feeling of not really being able to enjoy things most days for at least 2 weeks. And often depression also affects both the way that we see the world. So we tend to see the world through the opposite of rose-tinted glasses. So we tend to see the world as viewing us as worthless. We might feel guilty. We might lose our optimism. We might feel hopeless. Thoughts that actually the world might be better off if I wasn't here, or I might be better off if I wasn't here, quite common within depression. So they're the feelings, but the other kind of hard signs to look out for are physical signs. So people's sleep goes off. There's a change in their appetite, either reducing or increasing. People often feel worse in the mornings. There's a lack of energy. So there's those are kind of key signs to look for depression. As I say, you only really need those signs for most days for a few weeks. And at that stage, I would start to wonder if I'm depressed and I might seek further advice and treatment for that. It doesn't help to ignore those for too long. And talking therapy was the first step. There are some screening tools available free on the web. And I linked to them in the book as well, but anyone can find them. The PHQ-9 for depression, really good screening tool, very simple to use. And the GAD-7 is for anxiety. So if you are thinking, am I tipping into anxiety or depression? Just do one of those and you'll get a score, and that score will give you some advice about what to do next.
That's really, really helpful. We also provide a free toolkit called Am I Stressed, Overwhelmed or Burnt Out? And it contains all the burnout free inventories as well. But what I might do is add into that the GAD-7 and the PHQ-9 that people can access just to make sure. And obviously getting your book would be really good. But as you said that, I'm thinking, well, gosh, it's actually very difficult to tell, because you get fatigue in burnout, you get fatigue in depression, you get this sort of cynicism, don't you, and emotional detachment in burnout, and then you get this hopelessness in depression, which is probably why it's so important to actually seek professional help, because they'll be able to sort of tease it out and work out what's really going on for you.
Yes, and it is important it's teased out, because burnout is different from anxiety and depression, and we'd use a different approach. So for example, I wouldn't consider antidepressants in burnout, but if a talking therapy hasn't resolved a depression or anxiety, or it's very severe, then it's worth considering. I think if you're wondering if you're depressed and you're getting those physical symptoms, so your sleep's going off, your appetite's going off, you might be losing weight, you've got an awful lot of kind of fatigue, especially in the mornings, it might push you a little bit more to thinking this might have tipped into depression. But once again, depression, anxiety, really easily treated. So don't worry, just come through for help.
And a lot of the treatments are very similar to the treatments of burnout, aren't they? Which is good news, which is really good news, which shows why it's so important to go. This might be, again, talking about some of these talking therapies, but there's a chapter in your book all about what we bring to the table, which I found fascinating, because we know that not all burnout is the same. As Paula Redmond said, that there's different causes. It might be due to moral injury, or it might be due to just pure work overload, or it might be due to sort of underconfidence in ourselves and things like that. So what other things are these sort of, could be some of the underlying causes? I know you mentioned attachment theory, and then there's moral injury and things like that, but what do you typically see in some of your patients?
So I'm going to start this with a kind of warning, which is, I firmly believe when I'm meeting people in my clinic that they've burnt out because of some change in the system. So, whatever their personalities or coping systems are, they've often been doing perfectly fine for many years, and then something's changed. So it's not the cause of burnout. So I want to be that, but we do see some things. So Herbert Freudenberger, who I mentioned, who was the wonderful psychoanalyst who first coined the term burnout. One of the first terms he toyed with around burnout was superachiever syndrome. And the reason he did that is because he said there are some people who are really dedicated, work really hard, really want to make a difference. And for them, they will work very hard. They'll try and do a lot at home. They won't necessarily reach out for support. And that is a group that are vulnerable for burnout. And the group that are vulnerable for burnout in the NHS, I think, because I think our organisations take advantage of those superachievers. So I'm utterly amazed when I meet healthcare professionals who are allowed to work ridiculous hours, allowed to wear too many hats. These are superachievers, and they've been allowed by their organisation to burn out. And I kind of think, how did the organisation think this was going to turn out? What did they think was going to happen here? But that happened. So there is this idea. The other thing I think is really interesting, and then I'll move on to attachment, is there's a double-edged sword in high-performing professionals. So high-performing professionals tend to be conscientious, they tend to be determined, and they tend to be quite outgoing. Not always, but they tend to be. Now that's good. They're the sort of people you want to recruit often. But under pressure, those same characteristics can become a kind of Achilles heel. So your conscientiousness can become perfectionism. Your determination can become obsessionality. And your outgoingness can become kind of a little bit of narcissism. So you stop listening to people, you stop taking advice. So it's interesting that the things that make us really good at our job under stress can also get in the way of us doing our job really well. And then the final thing I'll talk about is attachment theory, which is something I'm interested in for various reasons. But one things that I tend to see in doctors particularly, but other high-level professions, I've seen lawyers like this, is a couple of typical attachment patterns. One is a dismissive attachment pattern, where we play down our emotions and our relationships. So this is the doctor who just kind of keeps a stiff upper lip and just gets on with it, just kind of manages things, often very effective. But the problem is with this doctor isn't necessarily processing their emotions. So there's an emotional impact of work, but they're just getting on with it, going from one thing to another, dismissing their emotions, and eventually that can catch up with you. The other attachment style I tend to see in medics, but less common than dismissive one, but it's there, is a preoccupied attachment style, which are these medics who are the opposite of dismissive. They really, really prioritize emotions and they prioritize relationships. So a typical warning sign for a medic that I meet with this is they tell me they've never had a complaint. So these are these wonderful medics who keep everyone happy. And that is great. That's great. But it takes a big emotional toll doing that and keeping everyone happy. And what these medics can do is they tend to neglect their own needs by prioritizing the other. So attachment's very interesting. I also think it's interesting because if we recognize we're in one of those attachment styles, it might inform what sort of therapy we want. So if we're dismissive, don't really do emotions, we might be attracted to CBT. Let's get our thinking right. But what we might more benefit from is a relational type therapy where we can actually look at our relationships and things like that and how we process emotions. And similarly, people who are preoccupied, really in touch with emotions, often think, well, I want a relationship therapy. I want to do something where I can think about my emotions. Whereas actually they might be more beneficial from CBT, because what they might benefit is a more structured approach that helps them kind of prioritize their self-care and helps them kind of order their thinking and their relationships. So I think it's really interesting.
That is really interesting. I remember reading about that in your book, actually, and thinking, gosh, I'm the sort of person, I'm an Enneagram 7, so I'm like, don't like to feel difficult emotions, like to move on and have fun. And actually what I've been thinking for a while, actually, some therapy where you are really looking, you can, emotions, feelings, somatic, where am I feeling that would be really helpful, rather than, just staying in your head and thinking it through. Just really quickly, what would have been the underlying cause of those two attachment styles?
Yeah, well, attachment tends to be, they tend to be styles that will start to develop from childhood. So most of us are securely attached. So, and most of the people I meet in my clinic are securely attached. But you might become dismissive of emotions and relationships if you're the sort of if from a young age you're kind of expected just to get on with it, perhaps not talk about emotions, and perhaps look after someone else. There's quite a lot of medics who've kind of been in a carer role from quite a young age, and so they might need to have put their needs to one side and just get on with it and manage things. And that could lead to a dismissive attachment style. We also train people. You talked about, what we're doing in A levels and med school and things. Unfortunately, we can sometimes train people to be dismissive. So we can train them just to get on with the next thing. Don't think about how you're feeling, just do the next exam or the next case and things like that. So we can encourage that, unfortunately. Preoccupied people tend to be the children who perhaps have been very sensitive, very caring for others. They again might have been in a caring role, but in a different way. They might needed to be particularly attuned to someone in their family and look after them in that way. So that might create a preoccupied attachment style, but it's complicated. And some people might have features of both. So it's not always a straightforward thing.
And that's probably where a skilled therapist would be really, really helpful to help you identify those underlying things and then what you can do about it, right? What would your top 3 tips be for someone who can recognize themselves on that plateau and thinks, oh crumbs, okay, maybe I want to do something right now before I get to that burnout cliff? Just the 3, well, let's say rather than 3 top tips, because all your top tips are in the book, your 3 next actions.
First thing is, fantastic. They are thinking about what's going on. Have I got problem stress? Have I got burnout? So they've stopped. Fantastic. And they've reflected. The next thing they should do is reach out for help. Nip it in the bud. That could be to a support organisation, like NHS Practitioner Health if you're a healthcare professional, or it could be to a coach, or it could be just to friends and family. Let people know how you're feeling. People often carry this alone and in silence. Don't do that. So stop and reflect, reach out for help. And the next thing is be hopeful and positive, because actually by reaching out for help, you will do incredibly well. People do incredibly well. They make amazing recoveries. And in fact, some people, quite a lot of people, if they have time to stop and reflect and recover, say, actually, I've developed through this. I feel different. I've made important changes and decisions, and my life feels more aligned now. So be really hopeful. Coming through to help is a positive thing.
Yeah, and that was another great chapter. Your book on sort of post-burnout growth, post-traumatic growth. So actually often, the good news is that after a burnout, people can actually be a lot better or feel a lot better than before, but you don't actually have to go through the whole massive burnout thing to get there. You can actually nip it in the bud and then be better, right? So let's avoid that massive dip, shall we?
Yeah, that's right.
Thank you so much, Richard. We'll have to get you back because no doubt we'll have lots more to talk about. And if anyone's listening to this, you've got questions for Richard, please just email them in. And Richard, if we get some questions, will you come back to answer them?
Oh, I'd love to.
That would be wonderful. And we'd love to have you back and to talk about this more, because it's such a big, big thing for doctors. Well, 50% of doctors working in burnout. So whether you're a doctor, dentist, nurse, other healthcare profession, we have accountants, lawyers and teachers as well. And I would think that their levels are pretty similar. But for me, the big revelation has been, you might be in burnout, but your performance is still okay at work because you've protected that, but the performance everywhere else is down, and then suddenly you're going to crash. So thank you so much for being here. If people want to get hold of you or find out more about the book, about you, about your work, where can they go?
So, yeah, well, I haven't got a web page, but I'm on LinkedIn. Always really happy to hear from people. So, Richard Duggins. And if people want to know about the book or the audio book, all good bookshops, it's on Amazon too.
And of course, if you are working in the NHS and you are eligible for practitioner health, it's a fantastic organisation. Richard, just remind us who it serves.
So it serves any healthcare professional who is finding it difficult to get confidential local support. So that's every doctor and every dentist in the NHS can come through, or it's any health professional who hasn't got local confidential support.
So do get in touch with Practitioner Health. And if you're not in the UK or you can't access that, there will be other ways for you to get help. It might just take 5 minutes of digging around and Googling. So employee assistance program, your own GP, your family practitioner, please don't struggle on alone, even if it's just telling a colleague about it. So thank you, Richard, and hopefully speak again soon.
Great. Thanks so much, Rachel.